Good morning, everybody. Welcome to Refresher Course 1611, Neuroimaging in Dementia. My name is Frederick Warkel from Amsterdam, and I'm your chairman for this session. This is a so-called integrated type of refresher course. There are two types, one with just 3 presentations, and that's it. This one is a so-called integrated type, meaning that there will be a brief introduction by me to set the scene for the topic. Then we have 3 slightly shorter lectures of each 23 minutes, allowing us to have about a quarter of an hour at the end to have some discussion, questions. So we will entertain some questions about the integration of these modalities in clinical practice. But it's also up to you to come up with your questions or ideas of how this can be done or how this can move forward in the future. And before I start, may I remind you to switch off your electronic devices or your phones that make noise. And please also fill out the evaluation forms and drop them off when you leave the room. Just as a background, these are, I guess, very familiar type of graphs that you've seen about the prevalence of dementia by age. This is from the European registries. And as you note, the percentage of people having dementia at the age of 65 is very low. It's on the order of 1%. And if you go to about the age of 85, it goes up to 20–25%. This is in men. It looks almost the same in women, with the subtle difference that the y-axis has now changed. So the prevalence in women is rising slightly steeper than in men. It depends a little bit on what registry you look at, but these are, of course, frightening figures. And because of that, and because of the increasing life expectancy in Europe and around the world, the prevalence of dementia is rising sharply, and I guess all of you have noticed that there's a very strong increase in demand in imaging for patients with suspected dementia. Hence, this is a popular topic. Also, this is a picture of our memory center that was refurbished a couple of years and opened by the Queen of the Netherlands, who since then resigned, by the way. We now have a king, and it illustrates, I think, the fact that we've got such a great demand for imaging, with 15 to 20 new patients being screened every week, and then on top of that, second opinions. So, for example, in our hospital, we easily scan over 500 people with dementia each year. This is the workflow in our dementia center briefly. Where we try to combine patient care and research, and there's a maximum waiting list of 6 weeks between referral and initiation. Then everybody is screened on a single day, intake by the neurologist, but also by a nurse. Neuropsychology is done, MRI is done on fixed slots. All of them get EEG, blood, and if possible also get CSF. And then that same week all the results are discussed in a multidisciplinary setting, and we try to come up with the most likely diagnosis, and people come back a week later to get the results of that. If needed, there will be additional investigations planned. If it's all clear, that's done, and they get our advice, and then they go into an annual follow-up. And in parallel, we get informed consent from them to collect materials, blood, CSF, use of MRI. Everything is rated in a structured fashion, goes into our database, and then accumulated over time for research purposes. In terms of imaging, especially structural imaging, and Mike Watjes will talk more about that after Professor Yousri has laid out the foundations in terms of understanding the medial temporal lobe and the limbic system. I think it all, of course, starts with a suspicion of dementia, but then various disorders need to be ruled out that may mimic dementia, metabolic disease, psychiatric things. Once you've done that, you can do then structural imaging. And as I said, Mike Watjes will consider this in more detail. And then Horst Urbach, the latest speaker, will then talk about when to do molecular imaging. And then the evaluation of the scans needs to be done in a structured fashion. This is far too detailed to be discussed in any level of detail at the moment, but you need to look at certain features and go through that in a stepwise fashion to come up with a conclusion. And structured reporting is very important. I've highlighted here how you can do that in terms of MRI, and it's explained in more detail in the book that we did on neuroimaging and dementia. looking at things that cause swelling, primary gray matter loss, vascular pathology, and then white matter pathology and disease, which may mimic dementia. So one of the important things is the medial temporal lobe. As I said, Professor Yousri will discuss with us the details of the hippocampus and its surrounding structures and how they're involved in memory formation and retrieval. And then Mike will go on to discuss rating scales and evaluation in clinical practice with CT and MR. But obviously, once we see the atrophy, this is late. Like for pathology, if you see the hippocampus is shrunken, many things have occurred well before that, such as formation of neurofibrillary tangles, and probably before that, deposition of amyloid, which may interfere with axons and then lead to these neurofibrillary tangles, but in an earlier stage may already interfere with the functioning of dendrites or even synaptic function without any morphological changes to the brain tissue. Fortunately, we can depict this now at a much earlier stage by looking at the amyloid deposition with molecular imaging, and there's an enormous gap between the initial deposition of amyloid and the occurrence of atrophy, probably on the order of something like 15 years. And therefore, PIP is very useful to predict who will, so this is an amyloid tracer, who will convert from mild cognitive impairment to AD or who will remain normal over time. And there's a series of tracers that we can use to look at amyloid. But we can also look at other molecular features that are related to dementia, the dopaminergic system, cerebral blood flow, and metabolism in general with SPECT and PET, and I'm sure there will be others to be discussed. So I'd like to thank my collaborator in Amsterdam, Philip Sheltons, the head of the Dementia Center, and Nick Fox, who's the head of the Dementia Center, or one of the leading figures, I should say, in Queen Square, where Tarek Yousri is working, and together we nicely worked on this book on dementia. So without further ado, I'd like to introduce Professor Tarek Yousri, who will now hopefully discuss the anatomy of the limbic system for us. Thank you, Tarek, for joining.